Good morning. Thank you. First of all, I'd like to thank Dr. Kornfeld and his committee for inviting me here and for putting this program together. I also want to thank Ron Wong, who prepared my PowerPoint presentation. Without him, I wouldn't have anything to say. And lastly, I would like to thank Dr. Bill Northway, Corky Roseanne, who recognized the problems that we were dealing with, were able to dissect it out, describe it, publish it, along with Dr. Porter. I'm sorry that Dr. Roseanne could not be here. He's 90 years old now, celebrating his birthday, but he was an integral part of the original paper talking about all the pathological changes that have occurred. Hope I can do this. Although supportive ventilation had been used for a significant period of time, primarily by Drinker and his co-workers, using the iron lung to provide ventilatory assistance, primarily for patients who had paralytic poliomyelitis, the use of positive pressure ventilation was really introduced in 1955 in the modern era by Dr. Ian Donald and his collaborators. Over a period of years, initially, while he was at Hammersmith, they started to ventilate the babies initially with a mask over the baby's face and then endotracheal intubation. And in a very short period of time, well, 8 years or 5 years, they ventilated 151 infants, 50 of whom survived. He also did some very interesting pulmonary mechanical studies on these babies. He published it initially in Lancet and then in the Scottish Journal of Medicine, which not many people here read. He was an amazing man, a Scotsman who did his postdoctoral work at Hammersmith and other parts of London, and he was primarily known as a person who developed, or was one of the people who developed ultrasound for use in monitoring pregnant women. Soon thereafter, there were several other reports of use of positive pressure ventilation. The group in Sweden ventilated a few babies. They had to do tracheostomies, and very few of those infants survived. Smythe and Bull ventilated babies with neonatal tetanus, and again, very few survived. In 1961, Mildred Stallman, who was at Vanderbilt, put a 1,500-gram infant who had severe respiratory failure on a negative pressure ventilator, the Monaghan, and that baby survived and grew up to be a normal child. Millie always had a picture of that child in her office. Working with her at the time was Willard Blankenship, who was a fellow, and in I think it was about 1970, they published a classic paper where they ventilated 81 infants using the negative pressure ventilator and had a survival rate of about 35 to 38%. I'm going a little bit ahead, but Blankenship took this idea with him when he was at George Washington Hospital in Washington, D.C., and one of the people he worked with was Roberta Ballard, and they published the paper using continuous negative pressure ventilation to take care of babies with respiratory failure, and they had an unbelievable survival rate of about 73%, which was sort of unheard of at the time. I think Roberta continued to use this when she came to Mount Zion. At that time, it was an Air Shields negative pressure ventilator. And if you get a hold of her during the lunch break, she'll tell you how the mechanism worked. But they did have a very outstanding success. Maria Delavoria Papadopoulos in 1962 placed the baby on a ventilator. That was about 3 months before we did. Dr. Hees from South Africa was ventilating babies who had neonatal tetanus. And then in 1964, Dr. Delavoria Papadopoulos, working with Paul Swire in Toronto, published their results of improved outcome of babies with respiratory distress syndrome. In 1962 was sort of a very important event. Dr. D. Vernon Thomas, who was a anesthesiologist, worked with Joe Daly and Bill McSweeney, who were senior residents at the time, and they placed a baby who had severe respiratory failure, was limp, unresponsive, severely cyanotic, and apneic. And they placed that baby on the ventilator, and that infant survived. And the baby was on the ventilator for about 4 days, able to be extubated, and that baby went on to survive. Unfortunately, she had mild handicaps, had marginal intellectual capabilities, but I kept up with that family until about 15 years ago when I lost track. But she did marry, and she did have children. Dr. Thomas then published a paper about prolonged respiratory use in newborns. We had 18 infants at the time, 11 survived. The longest period of treatment was 9 days. Our first babies were placed on the Bird Mark 8 ventilator, but the Department of Anesthesiology felt that that was a very precious tool, and they said, we don't want you to use it again, but you can use our old Bennett PR2s that were very sturdy. And we continued to use the Bennett PR2s through that time. Joe Daly, his name should have been on that paper, but he was away in Sweden studying with Peter Karlberg, and when he came back, he put together the experience that we had at the time ventilating babies and published this in 1971. This was over about a 2.5-year period that we were ventilating babies. 204 of these infants were ventilated, 36% survived. I should point out, when we look back at the data, when the babies were first placed on the ventilator, one of the faculty sort of specialed these babies. And it was either Dr. Thomas or one of the senior faculty that actually managed the babies throughout this time. And we had great input from our nursing staff who were very excited about this because they started to see babies survive. And they brought in a lot of ideas of how to, suction these babies, how to position them, how to keep the endotracheal tube in place, and how to provide physical therapy or respiratory therapy for them. And the outcome of these babies really was great. But then as we started to have house staff managing these babies, and the faculty weren't in the house all the time, we started to see a decreased incidence of survival with lots of complications. This is the old Bennett PR2. That was a very sturdy machine. These were the difficulties. We could not really regulate oxygen. The ventilators were geared so that you could get 100%, 40% of room air. There was no Veriflows, and they were introduced, I think, in the late 60s or early 70s, that you could actually try to control the amount of oxygen that went in. Initially, we didn't monitor PaO2s, but then in '64, we began to use umbilical artery catheters. These had been in use since 1958, initially by the group at Columbia's Dr. Stan James and Virginia Apgar were using indwelling catheters. And then we were able to use a Clark electrode to monitor PO2s. But of course, with the catheters, you couldn't keep them in for very long. The longest would be about 5 or 6 days, and then we would have to do peripheral arterial sticks, and they weren't easy to do, or we were damaging the vessels of these babies. The skin surface electrode was introduced, but on these small babies, they caused burns, and we weren't able to use those as well. Weaning techniques were poorly defined. I often used to say we'd come in and look at the baby and say, this baby's ready to be extubated. We do a virtual dance around the incubator, pull the tube, and hope the baby made it. We also had a very high incidence of pulmonary air leaks initially, but these began to decrease from about 35% to about 16 or 17%. We didn't know exactly how to put a baby on a ventilator, but Joe Daly developed a scoring system listed here. Most of the babies that we put on could not maintain a PO2 of greater than 40 torr while they were on 100% oxygen. They were either severely apneic or had a very low PO2. And it was interesting, over a period of time, we found that babies, if they had 50, would all go down to 40. And then we found that the vast majority who couldn't keep their PO2s above 60 would also drop below 40. So we put these babies on ventilators earlier and earlier. The major breakthrough, besides the work of Dr. Clements, who was synthesizing Exosurf at the time, was the work at UCSF. Doctors Gregory, Kitterman, Phibbs, Tooley, and Hamilton described the use of continuous positive airway pressure. And this was a major improvement in the treatment of babies with respiratory distress syndrome or with any form of respiratory failure. It was based on careful clinical observations, and since that time, every ventilator that's ever been developed or used incorporates N-positive pressure ventilation. And I consider this to be one of the major advances in the treatment of babies. Soon thereafter, Bob DeLemos, working with Kirby and with Dr. Bird, developed the Baby Bird ventilator, where you could control oxygen, control inspiratory, expiratory times, pressures, and rates. And this is a major advent in the care of babies. Stanford wasn't too excited about buying several of these for our nursery, so we were lucky because we noticed that we had one ventilator that had a sticky valve, one of the Bennett PR2s. And I told the respiratory therapist, whatever you do, do not work with this ventilator. Don't change anything on it. And serendipitously, we found, although we couldn't measure it on the Bennett, that we had inadvertent PEEP of about 2 to 3 centimeters of water. So Boyd Getzman, working with Johnny Johnson, Steve Furbaugh, and Arnie Goldstein, wrote a paper about the modification of the Bennett PR2 that improved our survival rate using ventilators with these adaptions from 34% to 60%. Not quite as good as Roberta Ballard's studies, but it was a marked improvement. That's the old Bennett PR2, and you can see, I don't have a pointer, but that little valve, you could control the oxygen concentration. The valves were useless other than telling us how high our pressure was, but it didn't tell us anything about N-positive pressure ventilation. And then, of course, during this period of time, as you heard, Dr. Northway, Roseanne, and Porter reported the findings of pulmonary problems with the use of prolonged ventilation. Dr. Cornfield talked about the Kennedy baby. I would be remiss in not mentioning this infant. This baby weighed over 2 kilos, was 34 and a half weeks gestation, and had severe respiratory distress syndrome. I often felt that if this baby were cared for at Vanderbilt with Millie, or up in Toronto with Maria and Paul Swire, or even cared for at Stanford, that this baby would have survived, because we were having very good results with babies who were over 34 weeks gestation, and they weighed over 2 kilos. Maybe the baby would have had a little bronchopulmonary dysplasia, but I'm pretty sure this baby would have survived. Thank you very much.